So now going on to screening, and before that, risk factors for diabetic foot ulcers. Many of you may be aware. When I started my residency, or when I used to understand diabetic foot from MBBS days, I thought ischemia is the most common cause, and there is poor blood supply, and that's why no healing. But truly speaking, that is a cause, but neuropathy goes above ischemia, and most common pathway or the most common risk factor in a diabetic foot is neuropathy, which is around 60 to 70% will have this who have an infected foot ulcer. Peripheral arterial disease, the prevalence in diabetic foot is around 35%. Poor glycemic controls, which is HbA1c, anything more than 8% persistently will give you high risks of a poor ulcer or an infection. Foot deformities like a Charcot's or Hammer's toes or all add to more chances of an ulcer and hence more chances of an infection. A past history of an ulcer or an amputation would have a 40% recurrence within the next 5 years. So you may have a history of ulcer or this thing that itself pushes you to have a recurrent ulcer or an amputation within the next 5 years. So this is the pathway for getting a diabetic foot ulcer and infection. So neuropathy, peripheral vascular disease, and microangiopathy. Neuropathy, somatic, autonomic, and all these reduce pain and proprioception, restrict joint mobility. The autonomic has an absence of sweating as well as impaired blood flow regulation. So how much is the demand in the supply? That gets impaired if there is an autonomic failure or autonomic neuropathy. There is absolute sweating, there is dryness, there is cracking of skin, so poor skin healing. Restricted joint mobility, your muscles or the group of muscles, they also undergo neuropathy and they would not coordinate with each other better, the internal as well as the external muscle group. And there is reduced pain and proprioception. You get injury, but you don't feel till it gets deeper, till it gets worsened. So this all causes small muscle weakness, increased foot pressures, and there is callus. Mind you, we have all seen calluses in the OPD and we behave very callous with this. So callous means very, very superficial kind of a behavior. But trust me, you'll see in the slides later on that callus is the pre-ulcer stage. And if you don't treat this seriously, make sure that you will get that patient again with an ulcer in a few days. So don't ignore a callus. In fact, one of my first learnings was how to debride a callus. It's very simple. As a surgeon, you may do complex surgery, but you have to address the callus. Absence of sweating causes dry skin and fissures, as said. Then the vessels or the microangiopathy causes foot ischemia. All these together would lead to a foot ulceration. Any breach in the foot or any breach in the skin causes a high risk for infection. So the other risk factors is, so you have more likely a diabetic foot conditions if you have an end-stage renal disease, presence of a foot deformity as we saw, limited foot and ankle joint mobility, and pre-ulcerative lesion or ulcer on the foot. So which are these pre-ulcerative lesions? This is just a few of them. An ingrown toenail you can see on the left, a callus which you can see in the middle. On the top, you can see a fungal intertrigo or a fungal infection in between the toes. These cracks and fissures you can see, and blister because of small shoe bites or small injuries because of improper fitting footwear. This is a diagram which shows that how a callus kind of leads to an ulcer and then an infection. So the first stage you will see, and below is one of my patients who in the center picture, you can see a blister in one side. Also, you can see that there is a hematoma. So there is a blister which came on the medial side. And this region on the right, you can see, which I have now removed the callus, actually had the underlying hematoma, which actually moved onto the medial side of the great toe and caused this blister. So callus causes increased pressure in this area, and that causes a hematoma underlying, which may lead to a future or most likely lead to a future ulceration, which gets secondarily infected. So the way to treat a callus is to remove the callus from the top and decrease the pressure on this part, and also give a proper customized footwear.